Thank you very much. First of all, I would like to thank the organizers for inviting me to participate in this interesting congress. And I will speak about attention deficit hyperactivity disorder in opiate-addicted patients, assessment and clinical features. I will speak about prevalence, about the diagnosis of ADHD in opioid-dependent patients, and finally, I will discuss some clinical features of opioid-dependent patients with adult ADHD. As an introduction, we have to remember that psychiatric comorbidity is very frequent in both disorders, in ADHD and also in substance use disorder. For one hand, substance-dependent patients show higher prevalence of ADHD, and for the other hand, ADHD patients present high prevalence of substance use disorder. The ADHD prevalent range is widely in addicted patients, probably due to methodological and sample difference. But there is an interesting meta-analysis, including 29 studies, in which the estimated prevalence of ADHD in substance use disorder patients was estimated in 23%. Also, we have to remember that ADHD and also conduct disorder in childhood increase the risk for future substance dependence. This is the meta-analysis that I comment. Specifically in opioid-dependent patients, ADHD has been less studied in comparing with other substance addictions. Some studies only consider ADHD history in childhood, and a clear estimation of the prevalence of ADHD in opioid-dependent patients is not well known. And also, the different studies have different results and have been found prevalence ranking from 4 to almost 25%. In this context, we had to clarify that it's very difficult, the diagnosis process, and there are some difficulties for assessment ADHD in opioid-addicted patients. One is the factor that that we have to consider is the frequent overlapping of symptoms and the need, the most of the time, of performance and retrospective diagnosis in childhood, because the most of the patients have not been diagnosed or have not been well diagnosed in childhood, and we receive it when they are adults. For one part, there are some factors that can conduce to the overdiagnosing and others that can conduce underdiagnosis. To avoid the overdiagnosis, I think it is very important to evaluate mental and physical comorbidity with similar symptoms to ADHD. It's not just a question of evaluate ADHD alone. We have to evaluate this disorder in a whole or integrated process. To analyze also, we have to analyze symptoms associated with intoxication and with double symptoms. We have to know that using screening tools without a future clinical diagnosis leads to overdiagnosis. And also we have to evaluate that some patients can do medication misuse. And for the other hand, there are some factors that conduct to underdiagnosis, and we have to consider the frequent cognitive deficit and biases associated with substance consumption. And also some clinical undervalue ADHD disorder. In this context, I think that considering the diagnostic difficulties and comorbidity relevance of substance use disorder and ADHD, a screening instrument can be very useful. There are different screenings, instruments, and also interviews. Today I will speak about two screening instruments. One is the BURS, and the other one is ARS. The first one, BURS, evaluates ATHD in childhood and for adult patients, and the ARS, the second one, evaluates adult ADHD. And also there are interviews that are longer and more expensive, no? And the interview that we use is the Conners Adult Diagnostic Interview, the CADI. But also there are like the PRIMS or the DAIGRE. What about the psychometric features of ARS and BURS? We have conducted a study with more than 250 patients applying the ARS and BURS. This is the ARS, the checklist. It's very short and very easy for the patient and for the clinicians. This screening has been studied by different groups, and the results of the general population in the original version was better than the result that we found when we work with a substance use patient, with patients with substance use disorder. And here we can differentiate some studies that have include several substance dependence, and also other studies that have include just, for example, alcohol. And in this case, for today, I have analyzed opiate dependent, and like it's possible to see, yes, we can see that the sensitivity and the specificity is in opiate-dependent patient is quite similar, or even the sensitivity is better than the results in other samples with substance use disorder. But the result is lower than in general population without it. In substance use disorder patient, the amount of false positive is very high, so we have to consider it always the need to be a clinical diagnosis. And in this sample, we estimate the prevalence of ADHD in adult patients with opiate dependence in 16%. And what about the BURS, the another instrument that I comment? This is the BURS. It's also very easy to apply. And in this case, the results that we have are less in comparison with ARS, but also there are some studies that have analyzed psychometric features. And in this case, we can see that the study in sample composed by alcohol dependence, and in this case by opiate dependence, the sensitivity and specificity is not so good if we compare the results in samples without this kind of disorders. Specifically, this result is very bad. So in this case, a lot of patients with a result positive will be false positive. So we have to consider this when we choose what instruments use in our clinical practice. In this sample, we estimate 18% of ADHD, of adult ADHD, of childhood ADHD in a sample of adults. We have some experience co-administering these instruments in alcohol, and What about clinical features of opioid-addicted patients with adult ADHD? We have some experience comparing psychiatric morbidity in cocaine-dependent patients, and also we have reviewed some clinical features of different substances. And when we focus on opioid-dependent patients with a comorbid ADHD, we found that the study usually show a greater prevalence of other substance use disorder, having described also a higher frequency of inclusion on methadone maintenance program, having described higher prevalence of antisocial personality disorder, early onset of use and dependence, and the ADHD is associated with more relapses. And I will present some unpublished data in a little study in which participate 5 treatment centers from Spain. The most of the participants was man with a mean age near 40 years old, and the most of them was unemployed. In this case, the percentage of positive Rs was 37%, but we have to consider that it's just a positive screening and no ADHD. Of them, 4.6% was a previous diagnosis of ADHD. And when we compare age, amount of consumption in the last month or on the 6 last months, we didn't find significant difference. But when we compare age of onset of consumption, we found difference. And we found that patients with positive R started to consume and develop the addiction earlier than patients with a negative result in this screening. And another study that we have in process now, we evaluate 252 opioid-dependent patients treated in our center in the Valdebrón Hospital in Barcelona. And we apply the interview, CADID, another interview, the Europasi, the European version of the Addiction Severity Index, the Zuckerman Personality Questionnaire to evaluate normal personality, and the SCIDI 1 or 2 to evaluate another comorbidity. About age and gender, we didn't find difference. And when we analyze personality, we found that patients with ADHD had more score in neuroticism anxiety, and it means that patients with ADHD have more frequent emotional anxiety, tension, worry, obsessive indexation, lack of self-confidence, and sensitivity to criticism. We know that neuroticism is a factor that usually correlates with psychopathology in general. Also, when we evaluate other psychiatric comorbidity, we found that patients with the diagnosis of ADHD in the interview also had more affective disorder in a significant way. When we analyze the other disorders, psychotics, or another personality disorder, they didn't find statistical difference. And finally, as conclusion, we had to remember that to talk about the validity of a test, in this case, we have to consider the context in which it is used. And in opioid-dependent patients, the screening, ARS, and BURS can be useful, but the diagnosis must be clinic. An opiate-dependent patient with ADHD can have higher comorbidity with other psychiatric disorders. Thank you very much.